Αγαπητοί συνάδελφοι, καλησπέρα σας. Θα ξεκινήσουμε το συνέδριο του ΩΜΑ υπό την αιγίδα του Ελληνικού Κολεγίου Οφθαλμολογίας, της εταιρείας Ιαλοειδούς Αμπιστροειδούς και της εταιρείας Ενδοφακών. Την άδεια βέβαια την πήραμε με το Ελληνικό Κολέγιο Οφθαλμολογίας. Είναι τα 30 χρόνια λειτουργίας του ΩΜΑ, Οφθαλμολογικού Ινστιτούτου Αθηνών, και έχουμε τη χαρά να διοργανώσουμε ένα πολύ δυνατό συνέδριο με καταξιωμένους συναδέλφους από την Ελλάδα, από όλη την Ελλάδα και το εξωτερικό. Για να μην σπαταλήσουμε το χρόνο μας σε λόγια, για να είμαστε σωστοί στο χρόνο μας, θα καλέσω στο βήμα την κυρία Μαρία Πευκιανάκη, εξαίρετη συνάδελφη, η οποία μας έχει έρθει από Αμερική και Αγγλία, η οποία έχει οργανώσει μίας ώρας μια στρογγυλή τράπεζα, θα μας πει η ίδια, με εξαίρετους συναδέλφους, οι οποίοι είναι από το Ισραήλ, την Αμερική και την Ινδία. Δίνω αμέσως το λόγο στην κυρία Πευκιανάκη να παρουσιάσει τους καλεσμένους και να αρχίσει τη συνεδρία.
Καλησπέρα σας. Εγώ θέλω με τη σειρά μου να ευχαριστήσω και εγώ το Ελληνικό Κολέγιο Οφθαλμολογίας και το Οφθαλμολογικό Ινστιτούτο ΩΜΑ για την πολύ ευγενική και τιμητική πρόσκληση να συμμετέχω και φέτος στη διμερίδα τους και να οργανώσω στα πλαίσια της διμερίδας το δεύτερο οφθαλμολογικό φροντιστήριο. Αν μου επιτραπεί ένα λεπτό προσωπικού σχολείου, θα ήθελα να ευχαριστήσω ιδιαίτερα θέρμα όλα τα μέλη του Οφθαλμολογικού Ινστιτούτου ΩΜΑ, το προσωπικό, το Διοικητικό Συμβούλιο και ιδιαίτερα τον Πρόεδρο, τον κύριο Δατσέρη, για την πολύ θερμή φιλοξενία τους όταν επέστρεψα στην Ελλάδα μετά από χρόνια στο εξωτερικό, που μου επέτρεψαν να κάνω αυτό που έχω μάθει καλά. Οφείλω να ομολογήσω ότι όταν είχα έρθει στην Ελλάδα δεν ήξερα, έλειπα και χρόνια, ότι αν υπήρχαν οφθαλμολογικά κέντρα με εξοπλισμό ανάλογο των κέντρων του εξωτερικού, γιατί για τη δικιά μου εξειδίκευση ο τεχνολογικός εξοπλισμός είναι το α και το ω. Και ήταν πολύ ευχάριστη έκπληξη όταν διαπίστωσα ότι ο τεχνολογικός εξοπλισμός του ΩΜΑ όχι μόνο είναι εισάξιος με αντίστοιχα μεγάλα κέντρα οφθαλμολογικά του εξωτερικού, αλλά σε πολλές περιπτώσεις και ανώτερος, και νομίζω ότι αξίζουν συγχαρητήρια και στο Διοικητικό Συμβούλιο και στον Πρόεδρό του για την πρωτοποριακή πρωτοβουλία για τα δεδομένα της Ελλάδας να ανανεώνουν συνεχώς τον εξοπλισμό τους. Κλείνω εδώ πέρα την παρένθεση για να σας πω ότι είμαι ιδιαίτερα χαρούμενη φέτος για το δεύτερο αυτό οφθαλμολογικό φροντιστήριο. Συμμετέχουν άτομα πάρα πολύ γνωστά στον χώρο της οφθαλμικής ογκολογίας. Όταν εγώ ξεκίνησα να κάνω την υποεξειδίκευση στην οφθαλμική ογκολογία, για μένα αυτά τα άτομα ήταν μύθοι και αισθάνομαι ιδιαίτερα συγκινημένη σήμερα που τα άτομα αυτά τιμούν και εμένα προσωπικά και μου δείχνουν εμπιστοσύνη και θα μιλήσουν στο δεύτερο οφθαλμολογικό φροντιστήριο που κάνω φέτος. Οπότε αρχίζουμε σιγά σιγά και να πω ότι good afternoon, ladies and gentlemen. It's my great pleasure to welcome everyone to our second Athens International Ocular Oncology course. Our speakers today need no introduction. It's a real privilege for me to welcome this afternoon very well-known speakers from the best ocular oncology centers worldwide who will be training with us, who will be sharing with us their valuable experience and insights. It's wonderful this year to see you here, and I would like to extend a special thanks and a special welcome to the colleagues who will be hosting this course from other parts of Greece, and especially to the colleagues who will be hosting the course from other countries. That it means a lot to us, and thank you. So, it's a tremendous pleasure that I will welcome Prof Murai to the second Athens International Ocular Oncology course. Prof Murai is a professor emeritus in ophthalmology and radiation oncology with the Bascom Palmer Eye Institute and founding director of Ocular Oncology Retinal of Miami, Florida. He has been involved in the evaluation of novel treatment approaches for ocular melanoma, for retinoblastoma, for vascular tumors, and has published over 400 peer-reviewed articles, and he has been recognized and with honor and senior honor award by the American Academy of Ophthalmology, the Association for Research in Vision and Ophthalmology, the Retina Society, the American Society of Retina Specialists, and our International Society of Ocular Oncologists. He's active on multiple editorial boards, and he's active editor and peer reviewer for the journals Retina, Ophthalmology, Archives of Ophthalmology, EOFS, Retina Today. This afternoon, he will be speaking to us about on surgical advances in the treatment of small choroidal melanoma. All that we are doing ocular oncology, we know that the early detection and management of small choroidal melanoma is very important. Before Prof will start the talk, just to say that if you have any questions, you can write down the questions in the appropriated box, and I will forward all the questions to Prof. Prof has to leave the operating room to give the talk today, to give us today the talk, and has to go back straight after his talk to the operating room, so there would be it won't be any time for the question, but Prof kindly will be happy to answer all your questions that I will send him by email. So, Prof, we are all here happy, and we are all hope that the next time you will be here live in Greece.
Thank you very much for having me join you. It's really a pleasure and an honor to be able to speak with you today. I'm in Miami, Florida, not quite as beautiful as Athens, and I'm very honored to be able to speak with you. So let me share my screen if I can. So today I'm going to talk to you about a real passion of mine, which is the management of small choroidal. This is one of the areas that is most controversial for our field, difference for our patients. So this is the tumor that we're talking about.
We do not see anything.
Αυτά συμβαίνουν δυστυχώς με τις ζωντανές μεταδόσεις. Λίγη υπομονή χρειάζεται.
See my screen?
Now, yes.
Yes.
All right.
Yeah.
I'm going to present the results of 100 consecutive eyes of 100 patients that had predominantly small malignant melanoma. All eyes that were evaluated had increase in the tumor size and/or increase in retinal detachment. And we're going to talk about a novel therapy where we directly ablate the tumor during vitrectomy with endolaser, peel the membrane in the ILM, do a fine needle aspiration biopsy, and then use steroids intravitreally to suppress inflammation. A big component of this is the advances in gene therapy so that we can look at cytogenetic prognostication and gene profiling for our patients. And for every patient in this series, we used the Castle Biosciences profile that looks at 15 genes using an RNA profiling schema that allows us to determine outcomes. For me, this has really changed how I manage small melanoma patients. One of the things that I think is critical is that early intervention enhances long-term survival for our patients. If a patient has a class 1A tumor, they have a 98% survival rate at 5 years. But if they have a class 2 tumor, they have a 28% survival rate, a massive difference based on the genetic profiling of the tumor. So in this series of 100 patients, the mean age of our patients was 68 years, as you would expect for most melanoma patients. 92% of our patients had an exudative retinal detachment, and 64% of our patients had the tumor increase. Because of the exudative detachment, the entry-level visual acuity was decreased in our patients to 20/80, and the mean tumor height was 1.9 millimeters. We had extended follow-up here of 79 months, so it has long-term outcome data. This is not a short-term trial. We use standard microincisional vitrectomy, valved surgery. Hyaloid was removed in all cases. The ILM was peeled. Laser the tumor, and then biopsy with tumor itself. Fortunately, we had very little bleeding, and then we saw steroid. This is what a patient looks like. This is a 74-year-old gentleman. You can see a base tension of 10/14, and patient had surgery with an entry-level 27 visual acuity. Here's the biopsy site. You can see it expands from the traction in this patient. Most of the times the biopsy is so out. This patient's vision improved to 20/40. The surgical findings are key. In every one of these eyes, there is direct intraoperative documentation of tractional changes on the tumor. I think that's really important to allow us to alleviate that, and it enhances the anatomic outcome for these patients. The retinal detachments are often subtle at the margin, and they're definitely evolved with a tractional component. We had no cases of retinal tear or regmatogenous detachment, and with greater than 5 years follow-up, the tumor's heights decreased from 1.9 to 1.4 in the mean. Only 2 of our patients had a progressive detachment of their pre-existing retinal detachment, and the vision improved from 20/40 at 6 months to 20/30 at 18 months, and has stayed around 20/30, 20/40 in 5-year follow-up. 92% of our patients are better than 20/40. That's really critical to remember, that the 2 things that we're looking for are local tumor control, enhancement of anatomic and visual outcome, and the avoidance of the potential for metastatic disease for our patients. None of the patients in this small tumor trial developed evidence of metastatic related mortality. 1 patient of 100 developed evidence of metastatic disease to the liver, a 1% 5-year metastasis rate. Tumors were controlled in all but 2 of the patients. 2 of our patients, both with tumors greater than 2.5 millimeters in thickness, had progressive recurrence of tumor, and we had 4 episodes of inflammatory events, and those were associated with the patients that had the progressive retinal detachment. What's interesting for me is in these very small tumors, we were able to get GEP classification in 98% of the tumors. For us, that's significantly better than what we've been able to do with cytopathology, and it really has been a key player in this. 94% of our patients presented with a class 1 tumor. 10% of those were 1B, which has a slightly higher concern for mortality, and 4 of those patients were class 2. What I think is remarkable is all 4 of the class 2 patients now with follow-up at 7 years have no evidence of metastatic disease. That's a unique finding, and it does to me suggest that early intervention has a significant benefit. So for our patients, melanoma treatment for uveal melanoma is significantly changing. We're always focused on how do we improve survival for our patients, but with survival, can we retain globe with both visual and anatomic function? And I believe that advanced vitreoretinal surgical targeting of these tumors, coupled with direct laser ablation and fine needle aspiration biopsy, gives us informative information from the biopsy itself, but also applies definitive treatment to the patient's tumor and has evidence of long-term tumor control with clear decrease in mortality. So for me, the take-home points for us are small tumor management, evolving to treating patients earlier, has the single greatest potential to decrease mortality from melanoma. Diagnostic accuracy, which has been controversial in the past, is critical, and I think we've become very, very good at evaluating small tumors and determining which tumors are at risk. And when you treat a small tumor, there are multiple new approaches to treatment, including the AURA-011 trial. It's imperative that we require excellent local tumor control. So for me, I cannot consider a therapy that does not have a tumor control rate about 90% or better, in this case 98%, and we must remember that long-term studies are critical. Short-term studies are not going to be able to evaluate both anatomic and mortality outcomes for our patients. So controversies remain. You're going to hear more and more about this shift towards smaller tumor treatment and what treatment options are available. And I think that one mainstay of this is that we're moving to treat earlier. We all believe that molecular tumor typing for prognostication is critical. And even though there is not a consensus, I think that local tumor ablation, as we've discussed here, is an excellent opportunity for our patients. And it broadens the ability for patients to be treated by not only ocular oncology specialists, by vitreoretinal surgical specialists with an interest in ocular oncology. So thank you so much for letting me be with you today. It's really a pleasure. Like any study, this is single institution. There is variable disease. It's a single surgeon, but I think it's remarkable in 100 patients followed for a minimum of 5 years with a defined treatment approach. And finally, I'd like to thank you for listening to me today and joining us, and I'd like to thank the patients and their families and my colleagues that have allowed me to take care of these patients for the last 3 decades. Thank you.
Thank you very much, Prof. If there are any questions, I will mail them to you. I know that we are very busy today, so it was really a big honor for me to be my second course. I hope to see you soon. Bye.
Thank you so much for letting me join you guys. Bye-bye. Have a great conference.
You too. Bye-bye. So let's go now to our second speaker. It's my great pleasure to present the second speaker of today's course, Prof Honavar. Prof Honavar is an ocular oncologist focused on tumors of orbit, eyelid, ocular surface, and retinoblastoma. He is counting among the top 2% of world researchers. Has achieved the unique distinction of being the first Indian ophthalmologist to receive the Life Achievement Honor Award, the highest award of the American Academy of Ophthalmology to its members. He currently heads the Department of Ocular Oncology, Ophthalmic and Facial Plastic Surgery at the Center for Sight in Hyderabad in India. Overall, his research contribution had very significant impact on the diagnosis and management of retinoblastoma and its outcome. He has more than 150 papers in peer-reviewed journals, and currently he is also a chief editor of Indian Journal of Ophthalmology. Sandoz will speak us today about recent advances in orbital tumors. We know that the knowledge of the orbital diseases and the management has continued to evolve in the past year, so we are all looking forward to hear his talk. Just to remind you that if you have any questions, you can write it down in the appropriate box of your screen for the persons who are attending the course online. Sandoz, we are here.
Yeah, thank you for this wonderful opportunity. I consider it a privilege to speak to this August gathering. I'm sharing my screen. I was asked to talk on current concepts in the management of orbital tumors. In fact, the first understanding of orbital tumors evolved with Pandora, who is from Greek mythology. Pandora's box is supposed to be full of evil. And if you look at orbital tumors, more than 50% of orbital tumors are malignant and are potentially life-threatening. So it calls for a logical approach to management of orbital tumors with the cooperation of oncological principles. Now, what are the oncological principles that we talk about? If you have a well-circumscribed tumor, we better completely excise it as long as it does not have any functional deficit. If it's a diffuse tumor, infiltrative tumor, excising which would cause functional deficit, then we do an incisional biopsy. Always provide histopathology guided adjuvant treatment following excision, and there is a role for multimodal treatment. I'll be talking about some of these recent concepts: non-surgical approach to orbital tumors, understanding of the role of orbital biopsy, how exactly to do it, minimal excess surgery, and the magic of multimodal therapy. This is an airline pilot, and he looks very normal to us looking at him. He doesn't even seem to have proptosis, maybe just a little bit proptosis in the right eye. But he was failed in the recent medical exam because of an orbital tumor that he had right at the orbital apex, impinging on the structures that pass through the superior orbital fissure. Consequently, he has visual field defect because of which he has failed the medical exam. Now, cavernous hemangioma is a surgeon's delight. We all would like to excise it. But what are the implications of meddling at the superior orbital fissure area? Maybe he will have a little bit of diplopia, or he may have further reduction in vision, which would preclude him from pursuing his activity, that is flying. So here we choose stereotactic radiation, 4000 centigrade delivered right to the tumor without any toxic dose to the optic nerve. And after 9 months, you can see that his tumor has shrunk to about 20 to 30% of its initial volume, and the visual field defect has completely reversed. He's back at work. There are reports in the literature about the use of gamma knife radiation, much lower dose, 2000 centigrade, for this orbital apical cavernous hemangioma, which has further reduced in volume and consequent resolution of visual field defect. So it's real that we can use radiation, low dose radiation, as an optional modality for the management of tumors which are in the shape of a pear, which are impinging at the orbital apex and superior orbital fissure. Whereas if you have a clear zone at the orbital apex and the tumor is in the shape of a sphere, we might as well excise it. Now going on to the role of injections. We have picibanil and bleomycin specifically for orbital lymphangioma. This is a young lady who comes to you with proptosis of the right eye. She is bothered about recurrent proptosis and subconjunctival hemorrhage that she has because of this lymphangioma that she has. Now look at the tumor. It is right at the posterior aspect of the orbit, surrounding the optic nerve, lateral rectus, superior rectus, LPS complex, and the medial rectus. If you were to debulk it even from the safe supratemporal approach, you're likely to have complications. Short of that, we inject picibanil, 2 injections, and you can see clearance of the intracorneal space, and she got the cosmesis that she always wanted. She's rid of her proptosis. That's the final appearance. Now, if you have a macrocystic lymphangioma, this child had proptosis of the left eye. She was attempted biopsy elsewhere with bleeding intraoperatively, so they abandoned the procedure and sent the child over. You can see a large chocolate cyst that's being evacuated. We generally do it either with ultrasound guidance or CT guidance, or without any guidance if the lesion were to be anterior and is palpable. And an equal amount of bleomycin is injected, and you can see nice results after a few months. This is a patient again with acute hemorrhage within a lymphangioma, approached similarly and with resolution. This is a patient with anterior lymphangiomas. The anterior component was debulked, and for the posterior component, bleomycin was injected with much better cosmesis a few months later. Again, an anterior lympangioma treated with bleomycin. The role of injection doesn't stop with lymphangioma. You have eosinophilic granuloma treated similarly. This child is a eosinophilic granuloma in the sphenoid wing, and it is eroding the orbital roof, and the dura is also affected. If you were to go by the classic approach of curettage of the tumor, then you might need neurosurgical intervention because this dura may be disrupted. Short of that, we do a biopsy from a sub-row approach, as you see here, right from the center of the tumor in a safe zone, and send it for intraoperative pathology. Once the diagnosis of eosinophilic granuloma is confirmed, we inject triamcinolone right into the tumor, and consequently 3 months later there is partial remodeling of the bone, and 6 months later there is complete remodeling of the bone without any major surgical intervention. Now what about orbital biopsy? We realized that 8 to 20% of orbital biopsies result in non-specific or misleadingly wrong diagnosis. That could be because of unrepresentative sample, non-uniform pathology, and you might have just biopsied the tissue reaction. So we classically do biopsy from superficial, mid-zonal, and deep, well past the epicenter of the tumor. So we have access to tissues at all the levels to analyze. Example is this child where the superficial biopsy showed only inflammation and fibrosis. So if you were to only do a superficial biopsy there, then you would mistake it to be a case of inflammation and probably treat the patient with steroids. Whereas the deeper biopsy showed rhabdomyosarcoma. So the current concept in biopsy is that we have to go right to the epicenter of the tumor. And if it's a deeper lesion and if you're not sure whether you've gone through the representative part of the tumor, you can always use intraoperative navigational devices to make sure that you are taking biopsy from the representative part of the lesion. There's a use of navigational system during surgery. So current concept about biopsy is that we take a layered biopsy from superficial, intermediate, and deep zones right past the epicenter of the lesion, which is judged by radiology, CT scan or MRI. And if at all you want an intraoperative diagnosis, then you can do a frozen section or imprint or squash cytology, and you can treat the patient appropriately, as was shown in a case of eosinophilic granuloma. Now coming to minimal access surgery, about 70% of the orbit can be accessed by transconjunctival approaches. We have medial, inferior fornicial, and lateral transconjunctival approaches. Only the superior orbit cannot be approached transconjunctively because we will be meddling with the levator palpebris superiors, which is a fornicial attachment. Inferior fornicial approach with a lateral canthotomy and inferior cantholysis gives very good approach to the orbit. This is a patient with orbital teratoma. Child was 3 weeks old when he presented. It was growing, and this is a fully grown tooth inside it, confirming that it is indeed a teratoma. Since the optic nerve was getting impacted by the tumor and there was disc edema, we decided to intervene when the child was 6 weeks old. That's the inferior fornicial approach with lateral canthotomy and inferior cantholysis. That is the lateral cystic component of the tumor. And as we progress, you can see this pearly white structure, which is nothing but the optic nerve, and then the solid medial component of the tumor. So this was the groove through which optic nerve was passing. That's the lateral cystic component, and that's the medial solid component, all of which could be visualized and removed by an inferior fornicial approach, which gave us a panoramic view to the orbit. All that the child has is residual esotropia, which needs to be repaired. So this is a young professional with an intrapurnal cavernous hemangioma. We know it is cavernous hemangioma, which is fairly easy to operate. So here we again go by the transconjunctival orbitotomy approach. We begin with a small lateral canthotomy and an inferior cantholysis to give better access to the inferior fornix. And then we make an incision right at the inferior fornix, just short of the inferior fornix. So this is about 3 to 4 millimeter from the lower border of the tarsus, all across. Retract the soft tissues and palpate the inferior orbital margin and make an incision very close to the inferior orbital margin, exposing the periosteum. The next level is incision in the periosteum, again close to the orbital margin, not damaging the infraorbital nerve. Dissect the periorbita carefully till you visualize either the apex of the inferior orbital fissure or the infraorbital nerve, that is the end point of periorbital dissection. Then cauterize the blood vessels and make an incision in the periorbita. Retract the fat on either side of the tumor and dissect the tumor under visualization to about 70 to 80% of its surface. Then apply a cryoprobe for anteroposterior traction and very gently supporting the tumor from posterior aspect, gently wriggle the tumor out. And as the tumor delivers out, we have to look at the posterior aspect of the tumor for a possible vascular pedicle, which needs to be cauterized to prevent secondary hemorrhage. And all we need to close now is the lateral canthotomy, re-establish the lateral canthal angle, and a few sutures through the inferior fornix. So these patients do very well. That's the kind of suturing that you do. There is no exposed wound except for a small lateral canthotomy. And that's the same patient after a couple of weeks without any stigma of a major orbital surgery. This is again a patient with cavernous hemangioma, anterior tumor, excised transconjunctivally. A much larger posterior intracorneal lesion accessed by transconjunctival approach. That was a fibrous histiocytoma, and this was a neurolymphoma accessed by the transconjunctival approach. You can see the infraorbital nerve, which was harvested along with the tumor, and that was by transconjunctival approach. Fibrous histiocytoma by the transconjunctival approach. The next aspect is histopathology guided adjuvant therapy. If you have a patient with solitary fibrous tumor, then or even if it's completely excised with cellular ATPR to prevent recurrence, we provide histopathology guided adjuvant treatment, that is external beam radiation. The next concept is about multimodal treatment. We realize that micrometastasis can be taken care of only by systemic therapy, that is chemotherapy. So in patients with the orbital lymphoma, despite the fact that radiation is possible and that can be curative for orbital component, depending on the stage of lymphoma, we might want to use systemic chemotherapy. As far as target therapy is concerned, it can be locally injected or can be systemic. This is a patient with conjunctival lymphoma. Predominantly the lesion is conjunctival, but there's a small component around the equator of the eye. If you were to excise it completely, then that would be difficult going all around the eye posterior to the equator. So the anterior conjunctival component was debulked. The residual, of course, can be treated by external beam radiation, but short of it, you can use perilesional rituximab, 3-weekly injections, 6 such injections, and the patient had complete regression of the residual orbital component. For melanoma, the mutational spectrum in the target therapeutic agents have been worked out, and there are instances in the literature where the orbital extension of a conjunctival melanoma started regressing following treatment with pembrolizumab, which was given for regional lymph node metastasis. Similarly, for nivolumab, again, there is evidence that it can take care of the orbital or the ocular surface component. This was a patient with ocular surface recurrence of a melanoma, and the patient was started on nivolumab for regional lymph node metastasis, and consequently, even the ocular component started regressing. So we have a role for using target therapy for inoperable situations, as in this case where erlotinib was used for a squamous cell carcinoma, which was inoperable in this elderly individual, and the tumor stabilized and remained so on erlotinib without needing surgery. This is a patient again from the literature where basal cell carcinoma with orbital extension was managed with vismodegib, and the tumor was stabilized. These are typically inoperable patients who are extremely sick or have systemic issues precluding surgery. Last bit is about multimodal management. We realized that many orbital tumors or eyelid tumors with orbital extension or even intraocular tumors with orbital extension were typically managed with orbital exentration. Of course, local disease can be controlled, but look at the systemic condition. Many of them ultimately succumb to metastasis. So we currently use multimodal treatment, which is a combination of sequential surgery, radiation, and chemotherapy. In orbital retinoblastoma, where there is 70% mortality with just orbital exentration, we use it with good effect. Example is this child with orbital component, which completely resolves with neoadjuvant chemotherapy, and eye goes into a comfortable phthisis, at which point you do an enucleation with a long optic nerve stump, deliver stereotactic radiation, and also provide adjuvant treatment. Does it work for optic nerve extension? You can see this patient has optic nerve extension right up to the orbital apex, precluding safe enucleation. Following neoadjuvant chemotherapy, optic nerve has returned to normal caliber, then we can do safe enucleation. It also seems to work for anterior intracranial extension right into the cavernous sinus, anterior part of the cavernous sinus through the superior orbital fissure. You can see following neoadjuvant chemotherapy, proptosis has resolved, eye has gone into phthisis, and all that is left is in the superior orbital fissure, which is amenable to stereotactic radiation. The bonus is cosmesis. Without having to do orbital exentration, you can do a safe enucleation in these children and fit them with a cosmetically gratifying prosthetic eye. In rhabdomyosarcoma, we use the same principle. Example is this child who has rhabdomyosarcoma all around the inferior rectus muscle. If you were to completely excise it, then you'd be sacrificing the inferior rectus muscle, thus there might be refractory strabismus and diplopia. So we remove the tumor, sparing a part of the tumor which is around the inferior rectus muscle. That wedge is spared, and the residual tumor was treated with stereotactic radiation and adjuvant chemotherapy, and the child has full function and complete regression of the tumor. Where we have to do orbital exenteration, we make the procedure safer by providing neoadjuvant chemotherapy. This child has undergone orbital exenteration with an orbital prosthesis. The most important use of multimodal therapy is in the management of adenoid cystic carcinoma of the lacrimal gland, where we use chemoreduction or neoadjuvant chemotherapy just like we do in retinoblastoma to reduce the size of the tumor, make it more compact, and then perform en-bloc excision including the periosteum that is harvesting it. Now this is one more patient where there is reduction in the tumor which is evident, following which the patient undergoes excision of the tumor. What is important is that we don't have to do orbitectomy or bone removal anymore. This patient has evident bone erosion, and following multimodal treatment, the bone is completely remodeled. This is a child again with adenoid cystic carcinoma with bone erosion, even involvement of superior orbital fissure. All that has got completely remodeled following multimodal treatment. For patients who have already undergone radiation, as this patient had elsewhere, and have orbital extension, paranasal sinus involvement, and limited intracranial extension, we can do multimodal treatment to reduce the bulk of the tumor. And then when we perform excision, we can do what is called afterloaded brachytherapy, where we implant silicone tubes and deliver iridium-192 as radiation source to treat the bed of the tumor. With this, this was recently published in OPRS journal. You can read it up, but basically we can reduce the incidence of metastasis to about 5%, much less than what we used to have earlier, 23 and 67% with conventional treatment. By using multimodal treatment, we can reduce the risk of metastasis and also save the eye in about 95% of patients. In sebaceous gland carcinoma, again, with orbital extension, you can see how nicely the tumor has regressed following 1 cycle and following 3 cycles. Now this patient, from being excentrated, has become amenable for local tumor excision. This is a patient, young individual with very rare form of sebaceous gland carcinoma involving the lacrimal sac. Somebody had done a DCR earlier, so it has got intranasal extension as well. Again, following multimodal therapy and dacrocystectomy, he is doing very well with complete local tumor control. And you can see that the death rates have reduced remarkably following use of chemotherapy as an adjuvant measure following conservative surgery, not orbital exenteration. In conclusion, I would say that the rapid new strides and paradigm changes in the management of orbital tumors, target therapy, new forms of chemotherapy, and innovative use of radiation and minimal approach surgery have provided better outcomes. Thank you so much.
Thank you very much, Sados, for your wonderful talk. Always, all the time, your presentation was so informative. Thank you very much. Any questions? I've got one more question regarding the orbital metastasis.
We don't hear you.
So we know that usually the orbit is not a common site for metastasis, usually. However, in the last years, we can find patients with orbital metastasis from cancer, from the breast cancer, or lung cancer, or prostate, either because of the longer survival of patients or better diagnosis. Usually, in those cases, do you have a specific protocol? Your treatment strategy or a combination with chemo and radio? Do you have a specific protocol for those cases, or?
Hear you well.
Sorry?
We can hear you well. There's some background noise.
So, did you listen to my question? So, there's a problem with. Are you able to listen us? No.
Yeah, we could hear the question.
Can I? Okay, you listen to me now.
Kobe, can you hear us?
Never mind, I will. Is it better now?
No, Maria, there is a background noise that comes on when you talk on mic.
Okay, so never mind. So, okay, so I will, now are you able to listen to me?
Yes,
Now it's better.
Okay. Perfect. So I was asking about the orbital metastasis. Okay. Usually we don't see metastasis. It's not so common, at least, to see metastasis in the orbit and ocular adnexta. Lately, we see patients with metastasis from malignancy of breast, of prostate, or lung, either because of the longer survival of patients with those type of cancers or because of better diagnostics. Do you have any specific protocol for those cases, or your treatment usually is palliative or a combination of chemotherapy and radiotherapy? Do you have any specific protocol for those cases with orbit metastasis?
Right. So each of the metastasis management depends on the primary malignancy. Depending on whether it is breast, prostate, lung malignancy, each of these primary cancers have a specific protocol which is based on many molecular markers. So we get complete information about the primary tumor first and then see how to customize treatment for the patient. If a patient has concurrent systemic metastasis, then it definitely in the realm of an oncologist to treat the patient systemically by either using chemotherapy or target therapeutic agents to control systemic metastasis. The patient may have concurrent metastasis both sides of the body.
Okay.
But in a rare situation where there is only orbital metastasis, first we would like to confirm the diagnosis by doing a biopsy and then treat the patient as appropriate. Many of these malignancies are amenable to chemotherapy, some of these are amenable to only radiation, and some are refractory to radiation where only orbital surgery or debulking of the tumor and adjuvant therapy would be indicated.
Okay.
It all depends on the primary treatment.
Okay, thank you. Any other question? No. Okay, thank you so much for your talk.
Thank you.
And hope to see you soon. And now we're going to our last speaker of today. It's a really very big honor for me to introduce Prof Pearce. Prof Pearce is the founder of the eye oncology field in Israel, appointed professor and chairman of the Department of Ophthalmology at Hadassah Hebrew University Medical Center. He served as a president of International Society of Ophthalmic Pathology, as president of the International Society of Ocular Oncology, was member of the Board of Trustees of International Council of Ophthalmology, member of the Board of Trustees and Vice President of ARVO, and this year also has become the first Israel to win the prestigious John Angle Award from the Association for Research in Vision and Ophthalmology. He has published over 250 papers and over 60 chapters in books. And this afternoon, he's going to talk to us about the management of Vitro retinal lymphoma, and I think this is a subject which is very interesting, not only for us, for the ocular oncologists, but for all the pathologists, for all the ophthalmologists. Please join me in welcome Prof Pearce. Prof.
Good evening, Athens. Do you hear me?
Kalispera.
Good. Okay, so first of all, thank you for inviting me. And I'm sorry that we couldn't do it in person. And I hope that next time we will visit Athens.
We are looking forward for that.
Yeah. So I'm going to talk about vitreoretinal lymphoma. And vitreoretinal lymphoma is the most common and most malignant type of intraocular lymphoma. It's usually a B-cell lymphoma, and all the other type of intraocular lymphoma are actually uveal lymphoma. Primary vitreoretinal lymphoma is usually associated with primary central nervous system lymphoma, and actually the eye, the brain, and also the testes are immunoprivileged organs, and the lymphoma in these organs are very unique. Primary vitreoretinal lymphoma is usually B-cell lymphoma, although we have, as you will see, also some T-cell lymphoma. The incidence of vitreoretinal lymphoma as well as CNS lymphoma is increasing, and in both immunocompetent and immunoprivileged patients. Intraocular lymphoma occurs approximately in 1/4 of the primary CNS lymphoma. On the other hand, in about 80% of vitreous lymphoma, there is CNS lymphoma. So it's very important to remember that in each case, when we have vitreoretinal lymphoma, we have to rule out CNS lymphoma. The intraocular involvement can appear before, concomitant, or even years after the CNS lymphoma. So how do we diagnose the vitreoretinal lymphoma? First of all, we have to suspect clinically, and we see vitreal cells, mainly in clumps, and in some cases we see yellow, white retinal infiltrates, and in recent years the OCT may be very helpful. But in order to make the diagnosis, we have to do a laboratory investigation. Usually we do a diagnostic vitrectomy. There are those who are doing only aspiration, but we believe that diagnostic vitrectomy is more helpful. And we check for cytology, for B and T cells, including immunocytopathology. Some are doing flow cytometry. And in addition, we have to check molecularly, PCR for gene rearrangement, mutated MYD88, and for us, very important is to check the cytokines, the IL-10, IL-6 ratio. Very rarely we need a real chororetinal biopsy. So the hallmark of vitreoretinal lymphoma is vitreous cells, as you can see here, and retinal infiltrate. And because of the cells, it's often misdiagnosed as non-responsive uveitis, and it causes late diagnosis. In OCT, we can see sometimes subretinal infiltrates here, small infiltrates, and sometimes very large infiltrates. It depends on the case. Cytology is still the gold standard, but it's the most specific test for diagnosis of vitreoretinal lymphoma, but as I'll show you, it's not the most sensitive one. Of course, we have to do it, and when we do it, we do immunocytopathology for CD20 for B cells and CD3 for T cells. And here in cytology, we can see the large lymphoma cells. Gene rearrangement is done after the PCR for amplification of the DNA, and we check for B cells the immunoglobulin, the heavy gene rearrangement, and for T cells the gene rearrangement of the T cell receptor. For cytokines, we use the ELISA technique. In lymphoma, the IL-10, the interleukin-10, it shows increased levels, as opposed to inflammation where we have increased level of IL-6. So when we check the ratio of IL-10, IL-6, if it's more than 1, we have to suspect vitreoretinal lymphoma. By the way, we can check IL-10 also from the aqueous humor by doing ACTEP, and it's sometimes very helpful. So when we compare the test in our hands, we see that although the cytology is the most specific, the cytokines, IL-10, IL-6 ratio is more sensitive with more positive and negative predictive values. So for us, cytokine in our hands is very important. And it's not only in our hands, it's also in some other series, even more than the MYD88 that in recent years is in fashion. Regarding sex and age, we can see that we have more women, and the average age, the mean age, is about 62, although we have some young patients. So when we have vitreoretinal and CNS lymphoma, where does it start? So in about 61% in our series, it starts in the brain, and in 30% in the vitreous and retina, and in 9% simultaneous. So every CNS lymphoma patient is sent to our clinic to rule out vitreoretinal lymphoma, and every vitreoretinal lymphoma we send for neuro-oncologists to rule out CNS lymphoma. As I said, the Vitro cells cause misdiagnosis of uveitis, and many of these patients are diagnosed very late. And as you can see here, it can be up to 100 weeks and even up to 200 weeks late diagnosis. Among the 79 vitreoretinal lymphoma patients with 130 eyes, as you can see, about 2/3 are bilateral. Sometimes it's not simultaneous bilateral, and we have to check carefully for the other eye, but in most cases, when it's bilateral, it's simultaneous. About 90% are B cells, but still in about 10%, we found T-cell lymphoma, and then I will show they respond well to the same way of treatment. Although the disease is called vitreoretinal lymphoma, we found retinal involvement only in about 38%, and in the others, we found only lymphoma cells in the vitreous. Regarding treatment, in the past, when we diagnosed the disease very late, enucleation had to be done. Radiation is still used in quite a number of centers, but I will mention something about it. And systemic chemotherapy, intrathecal chemotherapy, and intravitreal chemotherapy is also used with a good response. And in some centers, they use rituximab. So regarding radiation, the dose of radiation is usually not so high, but not so low as well. And the average is about 4,000 centigrade in fraction. However, recurrence is common, and the ocular toxicity for radiation is well known. Systemic chemotherapy had one problem. Although we can use various type of chemotherapy, the most common is high-dose methotrexate. All this systemic chemotherapy, either intravenous, intrathecal, or even with blood-brain barrier disruption for the CNS, there is a limited intraocular penetration, and therefore response is usually temporary and recurrence is common. So already in the last 35 years, there were experiments to use intraocular chemotherapy by injection into the vitreous, but the first series, the first protocol was published by Fishburne and his colleagues from Portland, Oregon, the group of Dave Wilson and Justine Smith, and later on we joined them in publication, and later on we published our results, and I will show you our results. The protocol for vitreoretinal lymphoma is injecting methotrexate, 400 micrograms in 0.1, and later on we inject in 0.05 milliliter, and we use in our full protocol in induction phase of 8 injections twice a week, then consolidation 8 injections once a week, and then maintenance for 9 months. Although in recent study that we have just published in British Journal of Hematology, we claim that maybe we don't need the maintenance phase after injecting the induction and consolidation phase. Overall, we have an average of 55 months of follow-up. All 130 eyes of 79 patients achieved complete remission, all of them. After about five injections. You can ask why we continue. We continue because those who stopped injection too early had higher rate of recurrence. We had follow-up of more than 1 year only in 71 eyes of 44 patients, because some treatments had to stop because of some patient died of the CNS lymphoma. Out of the 79 patients, only in 2 patients we had recurrence, and they responded well to repeated same protocol of treatment. And I'll show you some example. This is before treatment. Of course, I show you whenever we have retinal infiltrates, it's more photogenic. And I show you here the infiltration, and here after treatment. It's the same eye, although different camera. Here we have, again, infiltration into the retina, and this is after intravitreal injection of methotrexate. And here we have a series of the same eye. Here we have the clouds in the vitreous and the retinal infiltration. And already after one injection, we see a good response. And after 2, 4, 8, and at 8 and 10 injection with full response. This is another case. Again, a series. This is before diagnosis. And this is before treatment. While we were waiting for the treatment, we saw already progression toward the macula. But after 2 injections, 5, 9, and 16 injections, everything disappeared. Of course, with chemotherapy, we have also side effects. Most of the side effects are superficial, usually conjunctival hyperemia and keratopathy. Cataract formation, we really didn't have, but we had acceleration of existing cataract. We had some eyes with neovascular glaucoma, but today, whenever or as soon as we find it, we give injection of Avastin, and the neovascular glaucoma usually disappear. Maculopathy, we had only in cases that were treated also by blood-brain barrier disruption. I will not show you the results of the study because of short time. Those who die, those patients with vitreoretinal lymphoma that died, all died because of the CNS lymphoma. Nobody died of the eye disease, of course, okay? So those with vitreoretinal lymphoma who died, they died because of unrelated to their lymphoma. There was a claim in the past that additional involvement of the eye in CNS lymphoma worsened the prognosis. Not in our hands. We found that the prognosis, if CNS lymphoma is associated with vitreoretinal lymphoma, or if not, the prognosis is the same. And as you can see, there is not much difference in the survival time. Patients with vitreoretinal lymphoma without CNS lymphoma did not die with lymphoma. This is one of the very important conclusions. And ocular involvement does not worsen the prognosis of CNS lymphoma. And this is in spite of other who claims. We use the same treatment also for 2 cases of leukemia and 1 case of multiple myeloma, but this is just anecdotal in this stage. So in summary, intravitreal chemotherapy is using methotrexate is very effective with 100% primary response and rare recurrence. In most patients, it improves visual acuity. I didn't show you all the results because of short time, results of visual acuity. Side effects are usually superficial and temporary, and mortality rate is high because of the CNS lymphoma. As I mentioned, in some centers, they use intravitreal rituximab with good results, usually injecting 1 milligram of rituximab. We tested it in 3 patients, but the results were not as good as with methotrexate, although the side effects was much less. So, but we continue with our experience with methotrexate, but just remember that the rituximab can be an alternative, although still there is no defined protocol for using it. Thank you.
Thank you very much, Prof, for your very, very nice presentation. Unfortunately, we don't have much time for questions. I've got only one question. Prof, in case that you have a high index of clinical suspicion of vitreoretinal lymphoma, but however, you have negative results from the lab, what do you do in these cases? You repeat the PPV, you treat anyway, you are waiting for the development of the disease?
When it's totally negative, you know that in all the tests that we are doing, we don't treat, but we follow. But as I mentioned, if you do only cytology, it's very specific, but it's not sensitive enough. So we have also the cytokines. And if the cytokines levels, if the IL-10, IL-6 is high, we will treat the eye. So cytology is not enough. We use also the cytokines for the decision.
Okay, thank you very much. Thank you for it. Thanks everyone for your attention, and